Yes.
Good afternoon, everybody. So we are the fourth group. We are going to deal with the management and prophylaxis of COVID-19. Among us, five of us are presenting. Myself, Nila BK, and the other presenters are Naula, Parveen, Shakha, Sama, um, Sama. Okay. We are going to deal with the management and prophylaxis of COVID-19. Under this topic, we are going to cover different investigations of COVID-19, drugs which are used in its management, supportive measures during treatment, safety measures for prophylaxis, drugs for prophylaxis, and some myths about the prevention of the disease. We have collected the details from different sites such as PubMed, WHO, etc., and from some journals like the New England Journals of Medicine. Okay, that's all about our presentation. First, we are going to the investigations of COVID-19. So we know that until now there are no specific medications for this disease. So it is most important thing is the diagnostic test, which plays a major role in the prevention of the disease spread. So now we are going to the investigative methods. Next. The investigative methods mainly includes clinical examination and the other detection methods. The clinical examination primarily includes physical examination. The physical examination, we know that it includes the assessment of vitals. Most importantly, in a COVID patient, he will present with hypo or hypertension, tachypnea, tachycardia, rise in temperature, hypoxia, and severe COVID patients will present with hypoxemia, along with decreased oxygen saturation, and the ratio of partial pressure of arterial oxygen to that of the fraction of inspired oxygen will be low, and infiltrates will also be present in 50% of the lung field or more than that. On the next slide, we are going to see the blood investigation. In the blood investigation, it is manifested as high WBC counts along with lymphopenia and thrombocytopenia. The thrombocytopenia will result in microthrombi formation and will result in increased D-dimer levels on coagulation studies. Also, there will be raised inflammatory marker levels, raised levels of the biochemical markers such as LDH, procalcitonin, etc., along with a raised blood urea nitrogen level. That's all about the physical examination. Now, going to the thoracic imaging test. The thoracic imaging test includes X-ray and CT manifestations. X-ray manifestations include ground glass opacities and consolidations of the lung. Here we can see in the first figure, there are two black arrowheads showing hazy appearance of the lung field. This shows the ground glass opacities. And the next figure is the corresponding CT image. It also shows the presence of ground glass opacities, the hazy areas. And the next three figures, A, B, and C, presents the prognosis of a COVID patient. We can see the worsening prognosis, that is increased haziness in the lung fields can be seen. This is the image of increased consolidation of a COVID patient. In the next slide, we are going to see the CT manifestation. The CT manifestations also includes ground glass opacities, consolidations, and a reticular pattern. In the first figure, we can see the ground glass opacity inside the red box. There is a haziness of the lung field. In the second figure, we can see more dense haziness can be seen inside a red box in the lower right lobe of the lung. So that is the consolidation of the lung seen in COVID patients. In the third figure, we can see in the lower part of the lung, there is a red box. We can see their reticular pattern. This is the haziness which is seen in the reticular pattern, and this is manifested by serious COVID patients. The last figure presents with a modification of the reticular pattern, that is crazy paving stone pattern. It is more denser reticular pattern haziness. Okay, next we are going to the detection methods of COVID-19 along with the clinical investigation. These detection methods are also essential for the confirmation of viral infection in a patient. The important among them are lateral flow immunoassay, ELISA, PCR, NTS, and biosensors. We are going to PCR test now. Here, the viral RNA is detected. As we all know, the viral RNA first undergoes reverse transcription for converting into double-stranded DNA sequences. These DNA sequences will undergo ordinary PCR cycles, and finally, after hybridization, it will exhibit fluorescence due to the presence of probe, And from this, we can understand that the result of PCR cycles will depend upon the amount of fluorescent signals produced in this test. So the number of cycles which are required for fluorescent signal to be produced to cross the threshold limit is called cycle threshold or CT value. For COVID patients, the CT value should be less than 40 to be declared as positive, COVID positive. So that's about the PCR test. Next, we are going to the ELISA test. In the case of ELISA, the antibody present in the patient sample is detected. ELISA means enzyme-linked immunosorbent assay. Here we can see different components in the case of an ELISA kit. In the conjugation pad, we can see the SARS-CoV antigen. Next to the conjugation pad is a nitrocellular membrane, nitrocellulose membrane. In the nitrocellulose membrane, certain anti-human antibodies are present, which corresponds to the IgG and IgM antibodies present in the patient sample. When the patient sample is poured on the sample pad, it will proceed towards the conjugation pad. We know that IgG and IgM antibodies against the SARS-CoV antigen will be present in the sample of the patient. And these antigens will then combine with the SARS-CoV antigen present in the conjugation pad. Now this antigen antibody complex will proceed to a nitrocellulose membrane. Here, the antigen antibody complex will combine with the anti-human antibodies present in nitrocellulose membrane. Now, this hybridization of the antigen antibody complex with the anti-human antibodies will produce fluorescence, and this fluorescence will show that the virus particles are present in the samples of the patient. In the next slide, we can see how this fluorescence is produced in the case of ELISA. Look at the nitrocellulose membrane. We can see two control lines there, M line and G line. We can see the anti-human antibodies are present in M line and G line. These are corresponding to the IgG and IgM antibodies, anti-human antibodies. So when the antigen antibody complex from the conjugation pad binds to the corresponding anti-human IgG and IgM antibodies, there will be a color change in these anti-human antibodies. This is due to the presence of a chromogen which gets activated on this complex formation. In the case of COVID tests of ELISA, the chromogen used is tetramethylbenzidine. So that's about the procedure of ELISA test. Now we are going to see the results of ELISA, how it is said to be positive. The graph below, shown below, we can see that soon after the expression of the symptoms in a COVID patient, the IgM levels are going to increase, and the IgG levels in the samples of the patient are increasing only at a later stage. So in the case of ELISA test, it is said to be positive only if both IgG and IgM, or either IgG or IgM is shown positive in the test. And it is said to be negative if both of these antibodies, that is IgG and IgM, are absent in the patient sample. That's about the ELISA test and its result. Now we are going to some novel techniques for the detection of the virus. PCR and ELISA are the commonly used detection methods now. Among the novel techniques, the most important one is CRISPR, that is clustered, regularly interspaced, short palindromic repeats. It deals with the isothermal amplification of the COVID RNA molecule. Here, from the patient sample, we are isolating the COVID RNA. Actually, this CRISPR is a mechanism that takes place in the virus, in a bacteria for resistance towards a virus infection. When a virus infects the bacteria will incorporate some fragments of the viral genome into its own genetic material. And this pattern of the bacterial genome is called a CRISPR sequence. From the CRISPR sequence, the bacteria will produce certain complementary sequences of the DNA, which will which will combine with a protein called Cas9 on subsequent viral infection. Now, when the virus produces a subsequent infection on the bacteria, the bacteria will send the complex of Cas9 along with this guide RNA towards the original viral genome, and the hybridization of the complementary guide RNA with the viral genome will activate the Cas9 nuclease. Now, the similar mechanism takes place in the case of this detection method also. Here we are using Cas12 protein instead of Cas9, and a complex is formed between this Cas12 protein and the synthetic SARS-CoV guide RNA that we are making. So this complex will bind with the corresponding complementary sequence present on the viral RNA which is present on the patient sample. This hybridization will activate Cas12 nuclease. This Cas12 nuclease will now cleave the single-stranded DNA probe and thereby producing fluorescence. So that's about the CRISPR method. The next important novel technique is biosensors. The biosensors are most sensitive systems which can be used to detect even minor changes in the surrounding medium. And the changes can be electrochemical, piezoelectric, or optical changes that takes place in the surrounding medium of the transducer. The changes can be produced due to the formation of a product by the interaction between an analyte and a biological material. So these signals will be amplified and can be monitored. The first among the biosensors is localized surface plasmon resonance biosensor. In this type of LSPR biosensors, gold particles are activated or functionalized by coating them with a gold binding protein, enhanced green fluorescence material, and a SARS-CoV membrane antigen. All these are placed on the surface of the transducer, and the surface of the transducer is coated. Now, this antigen will combine with the antibodies present on the patient sample, thereby producing some changes in the optical field around the medium of this transducer. In the graphical representation, we can see that there are some changes in the electrochemical and spectral optical changes can be seen in the graphical representation. So that's about the LSPR resonance biosensor. Next one is the graphene-based field effect transistor biosensor. So in this case, the change is detected in the piezoelectric properties of the surrounding medium. Here, graphene, which is a piezoelectric material, is used. That is, here the electrons are freely mobile, and the surface of graphene sheet is coated by means of a functional group. In this case, it will be antibody of some specific membrane proteins or the spike proteins of the COVID-19 virus. When the antigen present in this patient sample binds with this antibody, the electrical oscillations of the electrons on surface of graphene plate will be hindered, and there will be some change which will be detected by the sensor, and corresponding signals will be produced. Or another means, we can also produce such changes in the piezoelectric characteristic by the combination of a synthetic DNA probe with the RNA which is present in the sample. So hybridization takes place, and resultant piezoelectric changes will lead to the detection of the virus. So that's all about the investigation methods of COVID-19. Thank you.
Next, continue.
Madam, can you hear my audio?
Yes.
Good afternoon, everyone. This is Naula, and we're going to talk about drugs for the management of COVID. So, consider a person who is COVID positive, means he infected with the virus. The virus has entered his body, and the virus is in search of the receptor, which is ACE2 receptor. And yeah, it is bound to the receptor, and now it enters the host cell, right? And there is endocytosis also. And after that, there is a replication of the virus inside the host cell with the help of the viral enzyme RNA-dependent RNA polymerase. So the treatment will be interfering any of this, either the entry or the endocytosis or the replication. Yeah, so any of this will be the treatment. So we have basically three subtopics: antiviral therapy, immune-based therapy, and adjunctive therapy. Adjunctive therapy itself is not the treatment of COVID. It is a supplementary part. The essential part will be antiviral and the immune-based therapy. So antiviral therapy, we have to start with remdesivir. Remdesivir, yeah, this one I said, either affecting any of the part of the entry or replication. Then we have a diagram also next, which is also explaining the same thing which I said. Now we'll move on to remdesivir. Remdesivir is a drug which is going to act on the replication part. it is to bind to the enzyme called as viral RNA dependent RNA polymerase, and so it will inhibit the viral replication. So we can say that remdesivir is going to cause a premature termination of RNA transcription. Okay, so this is an adenosine analog. It is an intravenous nucleotide prodrug. But the one thing to take care is remdesivir is a drug whose supply is so limited. So you can't give the drug to anybody who is COVID positive. Okay, this is highly prioritized. All the people who are hospitalized out of COVID and who need oxygen. Okay, I mean not severely deficit of oxygen. Those people will be given ventilatory support or extracorporeal membrane oxygenation and all. But yeah, moderately, if you need oxygen and all, to such people you can give remdesivir. And the duration of therapy will be, I think it's in the next slide, duration of therapy will be 5 to 10 days. So either if you give for 5 day or 10 day, the clinical benefits are almost similar. So 5 day or 10 days is fine. Then the adverse effect will be nausea, vomiting, increase in prothrombin time and all. But till today, there isn't any clinical trials conducted to check the drug-drug interactions of remdesivir. Now we are going to see hydroxychloroquine or chloroquine that can be administered with or without azithromycin. Okay, so chloroquine, we all know it's an anti-malarial drug, and hydroxychloroquine is an analog of chloroquine. So now this is going to act on the receptor part. Okay, so we have the receptor called ACE2, right, with which the the virus bind and enters the cell. So chloroquine is going to inhibit the glycosylation of that receptor. So if the glycosylation is inhibited, the virus cannot come and bind and then enter. Okay, so yeah, that's with chloroquine or hydroxychloroquine. Then the adverse effect is basically you have a lot of cardiac adverse effects like ventricular arrhythmia, QT prolongation, and finally, cardiac death and all. But if you use the drug for a long time, you will end up having bone marrow suppression also. Then we have other lopinavir, ritonavir, and all such protease inhibitors also. But the most important ones are remdesivir and the hydroxychloroquine, chloroquine, and all. The next one, we're going to see immune-based therapy for COVID-19.
Continue.
Okay. In immune-based therapy for COVID-19, okay, there is a concept of convalescent plasma. So convalescent plasma is, you're taking the plasma from a person who has just recovered from coronavirus. So his plasma is rich in all the antibodies, the neutralizing antibodies that has the ability, that has the potential to protect a cell from further infection of the same virus. So you take the plasma from that person and you transfer to a person who is just diagnosed with COVID. Okay, so to a person who is on the early phases of COVID infection will get this plasma, and that is one method. And then we have the immunoglobulin method also, where that's in the next slide, the immunoglobulin method, where you give intravenous immunoglobulins are given. So convalescent plasma is given to a hospitalized patient, and this will help him to recover from COVID-19. So risk is definitely there will be allergic reactions. Then they say there is lung damage and difficulty breathing, and you can think there will be the threat of HIV or hepatitis B or C infections and all, because this is all with blood transfer and all. Okay. Now we have immunoglobulins. So you can prepare an IVIG, which is an intravenous immunoglobulin. A high dose of IVIG can be also given to the patient who is COVID positive, which will have, this is written, this will have SARS-CoV-2 antibodies that you take from a person who has already been recovered from COVID, and you will give to a COVID positive patient. That is IVIG dose giving. Yeah. Then we have corticosteroids. Okay, so COVID-19 infection is a highly, it's a highly inflammatory state. Your body is going to develop a systemic inflammatory response, and that will lead to lung injury and finally to multi-system organ dysfunction. So you have to definitely give anti-inflammatory drugs. So one of the important one is dexamethasone, which is 6 mg per day up to 10 days can be given. This is given to a patient who does not require any supplementary oxygen. So you have to bring down the inflammatory stage in the patient. Okay, then interferons are given, interferon beta again. This is given to a person who is on an early phase of COVID-19, who have got mild and moderate symptoms, not so severe and all. Just mild and moderate symptoms is fine. So you can give interferon beta also. Then regarding interleukin 1 and interleukin 6 inhibitors. Interleukin 1 and interleukin 6, both of them are cytokines, okay? So they are inflammatory, they promote inflammation. So since COVID-19 disease, it's going to be a highly inflammatory state, you have to bring down the inflammation. You will have to administer these inhibitors of IL-1 and IL-6. So I've got an example for IL-1 inhibitor, which is Anankira. This is a recombinant human IL-1 receptor antagonist inhibitor. And this is given to a patient who is having severe COVID, okay? Yeah, so there are favorable responses seen to Anankira. If you give to a patient who has got high IL-1 and you give Anankira, it has been a good prognosis. Then IL-6 inhibitors, again, you can give to decrease the amount of IL-6 and then bring down the inflammation. Then we'll move on to next one, which is Bruton tyrosine kinase inhibitors and Janus kinase inhibitors. See, BTK, Bruton tyrosine kinase, and this JK, Janus kinase, both of them will mediate inflammation. So you have to inhibit that. So the drugs are acalabrutinib, and it's not imbrutinib. It's typed wrongly. It's ibrutinib. And similarly, JK inhibitors, you have baricitinib and ruxolitinib. Okay. So as I said, acalabrutinib, it is going to modulate the signaling that promotes inflammation. So it will always keep the whole thing under normal control. Inflammation, it's not going to cause inflammation. Okay. And similarly, ibrutinib is again improve inflammation and protect the lung from lung injury. Then JK inhibitors, baricitinib, also the same thing, but ruxolitinib has got certain other features, like it inhibits AAK1. What is AAK1? AAK1 is the one that promote the endocytosis of this. See, the virus will come to the cell and there's an endocytosis of this whole virus into the cell. So that endocytosis is mediated by AAK1, and ruxolitinib will inhibit that AAK1 and thus prevent the entry. Okay. And there is one more added benefit. We have something called as pulmonary AT2 cell. AT2 cell means it is the main cell of the lung, which will protect the lung integrity and stability. So you can imagine if that is being affected with COVID-19, the coronavirus, the whole lung will collapse. So again, ruxolitinib will protect or prevent the virus from entering and infecting that AT2 cell also, which was in the last slide. Okay. Now we have adjunctive therapy. I said this is an additional thing. This will go better with the other two drugs. This alone cannot do. Okay. Now we have antithrombotic therapy. Again, COVID-19 is a highly prothrombotic state. So you can give antithrombotic drugs can be given to people who have been COVID positive. So because they will form thrombus in the alveolar wall, the capillaries of alveolar wall, which will finally lead to lung injury, and also you have to give antithrombotic therapy has to be given. Then vitamin C, as we know, it's a good immune booster. Plus, the inflammation is mainly because IL-6 and endothelin-1 and all. So always vitamin C will keep them under control. The level of IL-6 and endothelin-1 is always kept under control with vitamin C. Then we have, next slide, we have vitamin D. So vitamin D is the one which is expressed on all the immune cells, the B cell, T cell, A, P, C. Okay, so we have more vitamin D, we have more immune cell. We have more immune cell, we have more immunity. So vitamin D has ultimately the potential to modulate innate and adaptive immune response. Then coming to zinc supplementation, the idea is zinc. See, if you have more zinc intracellularly, there is a decreased or an impaired replication of RNA virus. So more zinc supplementation, decreased RNA replication. This is how the whole thing goes. So that's all about my topic. Thank you.
Hello, ma'am.
Yes, continue.
I'm audible? Okay. So having heard all about the investigations and about the major management of COVID treatment, let's move on to the supportive measures taken up during COVID-19 treatment. So next slide. The supportive measures, these are extra measures which are to be taken along with the COVID-19 treatment, which includes even the symptomatic treatment as well as stabilization of the vital signs. This will synergize with the main COVID treatment so that this will finally lead to the improvement of the patient. So this includes giving adequate oxygen therapy, also stabilization of hemodynamics with the help of IV fluids and IV drugs, and management of COVID patients if they are under shock and renal problems. So next is about the modes of severities of COVID-19. In mild cases, the patient need not be hospitalized. They can be subjected to home quarantine and social distancing. And supportive measures are not required because SpO2 is well maintained above 94%. And in moderate cases, the patient starts presenting with slight clinical signs of pneumonia. So in such cases, if the SpO2 level is well maintained above 94, the patient can be continuously monitored. But if it goes below 90 to 94, then oxygen therapy has to be started. Then in severe diseases, it requires immediate hospitalization. Supportive treatment is very necessary because the saturation level of oxygen, SpO2, is much below 90. Critical case means immediate hospitalization is required and person has to be admitted into ICU or CCU because person might be under ARDS or may go for multiple organ failure. So to avoid fatality, the oxygen therapy has to be given immediately. COVID patients, mainly when the respiratory rate becomes beyond 24 breaths per minute, and when the oxygen levels, which are measured in the pulse meter, goes below 94 itself, we have to start oxygen therapy. The major oxygen therapy methods that are taken up during this COVID pandemic are the NIV, that is non-invasive ventilation, then you have HFNO, and invasive ventilation. So next is other simple oxygen sources that we use for oxygen therapy. So they are oxygen cylinders, oxygen concentrators, oxygen plants, and liquid oxygen tanks. As you can see here, this is the portable oxygen concentrator, and the one on the right is the stationary oxygen concentrator. And this down is the oxygen cylinder with attached flow meter, and here it is a patient who is under the oxygen therapy with oxygen cylinder. Then next is about the oxygen delivery devices. So it consists of nasal oxygen cannula with prongs. As you can see here, this is how it is being administered. The oxygen is given through a delivery tube. Then you have you have the rebreather mask and the venturi mask. So all these help to provide a high oxygen concentration and also at the required pressure. Depending upon the respiratory condition of the patient, we can even alter the FiO2, that is the total inspired, the fraction of inspired oxygen as per the condition of the patient. So next we go on to NIV. So first, we try with all these oxygen delivery systems and oxygen devices in the beginning, but if it becomes a bit more serious, we try NIV. NIV, it assists breathing by supplying a mixture of oxygen and air at a positive pressure, because this will help the patient to take deeper breath. And also, this is given via a special tight mask so that the air doesn't leak out. And one thing we have to understand mainly is that NIV is never an alternative to invasive ventilation, because we try this on a COVID patient, and we monitor the COVID patient for its vital signs. And if he is not improving out of his hypoxic state, then we have to shift to our conventional mechanical ventilation or invasive ventilation. So next, there are two. Okay, so this is the typical picture of non-invasive ventilation, and what you see on the right are the face masks which are usually used for NIV. That B is the most commonly used mask. So next, there are two types of NIV, that is given through by CPAP and BiPAP. CPAP means continuous positive airway pressure. So this is initially for the severe COVID-19 cases, the pressure that is fixed is 10 centimeter of water and 60% oxygen. So in CPAP, we have the inspiratory positive airway pressure, that is IPAP, equal to the expiratory positive airway pressure, EPAP. So a constant pressure of oxygen is being given to the patient. So this will help the patient to take in spontaneous breath. So it will help in the working of breathing for the person. But in case the patient is not showing any improvement, or if he's using accessory muscles of respiration, because that can go into respiratory fatigue. So we switch on, try BiPAP, that is bi-level positive airway pressure. Usually this is taken up when COVID-19 patients face comorbidities like COPD along with COVID. So here, unlike CPAP, in BiPAP, you can set the IPAP and EPAP pressure separately depending upon the condition of the patient. Usually IPAP is set at about 12 to 35 centimeters water, and EPAP and IPAP difference would be about 8 centimeter of water. So that's the pressure which is usually set. Next. So, however, there are contradictions. As we have already told, this is not a complete alternative. So if we have to keep on monitoring the patient who is under NIV, and even if after 2 hours there's no improvement, despite of the high positive pressure that we give, the oxygen that we give, then we can't continue with NIV. or if the patient has unstable hemodynamics, like the patient is going in for hypovolemia, hypotension, or heart problems like arrhythmia is increasing, this cannot be continued. Or as we told, a tight face mask is being used, airtight mask. So if the patient is facing some facial traumas or he's claustrophobic, that is afraid of closed spaces, then this will not be effective. And another important thing is that if we are not able to protect the respiratory tract, see, sometimes the gastric aspiration, the gastric contents can aspirate into the respiratory tract. It can block the respiratory tract, or sometimes excessive secretions will block the respiratory tract. In both cases, this cannot be continued. Finally, if the patient loses consciousness during NIV or goes for into a coma state, then this cannot be continued. Next. So next is HFNO. So HFNO is high flow nasal oxygen therapy. Similarly to it is similar to NIV. This is also given to the patient, and we monitor whether he or she is getting stabilized. If so, we can continue with this therapy. Very much convenient for patients when you compare it with NIV, because as you can see in the picture, a nasal cannula is being used, and oxygen is given at a high pressure. So this is better than the airtight mask which is being used. Patients can also eat, talk, and drink, so it will be more convenient for them. But these both are aerosol generating procedures also. So the hospital staff have to be well equipped. They should be knowing better and this should be continuously monitored also. So next, finally, if none of these are effective, we go for invasive ventilation or the mechanical ventilation, which requires endotracheal intubation. That is, we insert a tube into the trachea and provide oxygen at high pressure. So this is indicated mainly when there is airway obstruction, as we already told, when there is obstruction due to gastric contents or excessive secretions, we go for invasive ventilation. Or when there is unsustainable work of breathing, if the patient is using accessory muscles of respiration, or if there is respiratory hypoxemia, which we'll be talking in the next few slides, and hypercapnia, or when there is increased carbon dioxide content in the blood, or when the patient goes in for encephalopathy, invasive ventilation is recommended. So next is about the management of a COVID patient in case of severe pneumonia. So all the patients who are under oxygen therapy and who are facing severe pneumonia, they have to be first, as we told before, they have to be given the oxygen. Oxygen has to be given using the oxygen delivery systems. And if this doesn't work, we'll go for NIV and HFNO methods. We'll monitor the patient very well, see if the patient's SpO2 level, that is oxygen saturation, is going above 94% itself. We'll also take their blood and check every 2 hours whether their arterial blood gases are improving. And we'll also, along with that, we'll also monitor whether the patient is hemodynamically stable, and that there's no clinical deterioration and shock problems coming up, or else we have to give proper fluid therapy for that. Next is ARDS. ARDS is a more severe condition. So we do not go for NIV or HFNO. We directly go for invasive ventilation. So it is preferred that the person stays in prone position, and ventilation is given for nearly 12 to 16 hours per day. A fluid strategy has to be maintained if the patient goes for hypovolemia. And if the patient is having pain and distress during breathing, we can give sedatives and analgesics. And as we already told, if accessory muscles are being used continuously for respiration, we can go for respiratory fatigue. So to prevent that, neuromuscular blocking agents can also be given to a small extent. So next is about, yes, the refractory hypoxemia. Now, this is a very serious condition, because how much ever of oxygen therapy methods like NIV or HFNO, or even the invasive ventilation that we try to give, the patient doesn't respond positively. That means he keeps on remaining hypoxic. His SpO2 levels will be going below from time to time. So this is not a good indication, and none of these methods can be continued. So this is mainly because the lung parenchyma of the patient is damaging. So this can be rectified by a machine which is called ECMO, that is extracorporeal membrane oxygenation. As you can see here, this machine acts like an artificial lung, that is, does all the functions of the lung, including purification of the blood and exchange of gases, so that meanwhile the original lung heals up. So this has been found very effective in some of the COVID patients who have faced refractory hypoxemia, which has been said by the ECMO Society. So next is about the other supportive care which we have to take into consideration. Coming to volume depletion, when there's volume depletion or hypovolemia, we have to take isotonic fluid resuscitation. and hence that will help in maintaining the blood pressure and cardiac output. So this has to be continued during every step of mechanical ventilation. Next is next slide. Yeah, it's thromboembolism. So coagulopathy, arterial and venal thromboembolism, very challenge which is faced in COVID-19. So the first line treatment itself is enoxaparin, which is given 0.5 milligram per kg subcutaneously. This is the first line treatment. But if the patient is contradicting to the drug, or if it is more severe, we can even go for such devices which will give mechanical prophylaxis, like these intermittent pneumatic compression devices, also being used for cases like DVT. Next is about anti-inflammatory reactions. This has to be taken into consideration, or else the patient can go in for hyperinflammatory syndrome and finally multiple organ failure. So to prevent such complications, dexamethasone itself is given as a first line drug, IV or oral, usually IV if it is emergent, at a dose of 6 milligram once daily, even for 10 days. Then cough is actually a potential reflex that is there for almost all the viral respiratory diseases. So for this, first treatment will be giving sips of water and hydration. But if this is not working and if the patient's cough is increasing chronically, we can go for long-acting oral morphine, which is given 5 to 10 milligrams twice daily. Next is about delirium. Yeah, delirium is a state of unconsciousness. The person will not be conscious and will not be oriented in place and time. So first we go for non-pharmacological methods, like trying to regularly orient the person, avoiding constipation, giving adequate oxygen therapy, trying to reduce their pain and all. But if that doesn't work, we can go even for antipsychotics like haloperidol, which is given intramuscularly or subcutaneously. 0.5 milligram is usually given. And as we know, anxiety, depression, and sleep problems are common among COVID patients. So the first treatment we go for it is cognitive behavioral therapy, which will help to decrease much of the anxiety and depression problems. But if that is not effective, we can go for benzodiazepines, which will decrease the anxiety problems. And if the person is having sleep problems, we can advise sleep hygiene and tell them to avoid substances which are rich in caffeine, nicotine, and alcohol. Along with that, we can also advise stress management and relaxation techniques. So next is about the infections. Usually COVID-19 does not, 80% of the cases, it doesn't bring any secondary bacterial infection. But in case it happens, we can go for empirical antimicrobial therapy. That is, a specific microbe therapy can be given along with the COVID treatment. Now, in cases the patient is a HIV patient, and along with that he faces COVID, we have to continue the antiretroviral therapy of HIV along with the COVID therapy. Next is finally about the shock. The shock, usually we have the ABC care. That is, first we make the airway patent, then for breathing we give oxygen therapy, that is given 5 liters per minute, so that SpO2 levels is well above 90 to 94%. And we have to maintain circulation. So for that, fluid resuscitation is important, giving of fluids. And if it is septic shock, even antibiotics can also be administered. Finally, coming to renal problems, if the COVID patient is having renal problems, majorly suggested one is renal replacement therapy, RRT. Out of that, CRRT is more preferred because it is more automated. Just like we saw in ECMO, here CRRT just does the function of a kidney. It it regulates the water, electrolytes, and toxic products by continuous removal of solutes and fluid. So this is more automated than the usual hemodialysis than the usual IHT, that is intermittent hemodialysis. So administering CRRT is better in COVID patients because we don't require a extra health worker or nurse to come and intervene and make changes in the machine, because it is completely automated. So that's all about the supportive measures of COVID-19. Thank you.
Continue.
Ma'am.
Yes, continue.
Okay. Good evening, everyone. I'm Shalaba. I'm going to deal with prophylaxis, which includes drugs for prophylaxis and measures for prophylaxis. First of all, drugs for prophylaxis. Prophylaxis means actions to guard against the disease. For COVID-19, no definite drugs for prophylaxis have been discovered. So in order to keep our immunity intact, clinicians are using certain vitamin tablets such as vitamin D, zinc, vitamin C, vitamin E, etc. But These do not have any documented evidence about their efficiency. Similarly, for post-exposure prophylaxis, hydroxychloroquine and ivermectin were used in the initial stages but has no proof of action. So next. So as told earlier, there are no drugs for prophylaxis. So taking safety measures will help us to overcome it, which includes physical distancing, wearing a mask, and hand hygiene. Next. First of all, physical distancing. Physical distancing means maintaining at least 2 meters or 6 feet distance between ourselves and others to reduce the risk of infection when an infected person coughs, sneezes, or speaks. Then we can avoid the three C spaces, which is close, crowded, or involve close contact, and public transport. We can avoid interaction with strangers coming from other places and remain at home as far as possible. Next, we are going to wearing a mask. Wearing a mask means that the mask should cover our mouth, nose, and chin. And we should avoid frequent touching of face and mask. Hands should be cleaned before wearing the mask and after taking off it. Hand hygiene. Hand hygiene means washing hands should involve the following steps seen in the picture, that is palm to palm between fingers, back of hands, back of thumbs, back of fingers, fingernails, wrist, and rinse and wipe dry. Wash your hands after coughing or sneezing when caring for the sick when hands are visibly dirty. Next. Next is hospital precautions. Hospital precautions are the safety precautions that we have to take upon entering the hospital. That includes sanitization protocols, wearing personal protective equipment. Patient entering the hospital should be screened for high body temperature, and if any patient shows COVID symptoms, they should be immediately isolated. And that's all about prophylaxis. Next is.
Yes, continue.
Am I audible?
Yes, yes.
So coming to the last part, that is myths about the prevention of COVID-19. So chances are you have heard about a food, drug, or other method that claims to prevent, treat, or cure coronavirus disease. But while it might be tempting to use a product or method to stay healthy during the pandemic, it is extremely unlikely to work and might cause serious harm to our body. So here are some of the myth busters by WHO. 1. Disinfectants. Spraying and introducing bleach or chlorine into your body can be dangerous and poisonous if ingested, also causes irritation and damage to your skin and eyes. 2. Drinking alcohol. Drinking methanol or ethanol can be extremely dangerous. They will not kill the virus in your body and they will harm your internal organs. 3. Pneumonia and flu vaccines. Vaccines against pneumonia or flu do not protect you against the COVID-19 virus. 4. Temperatures. High temperatures. Exposing yourself to the sun or temperatures higher than 25 degrees Celsius, taking a hot bath, or using hand dryers does not protect you from COVID-19. Low temperatures, cold weather, and snow also cannot kill the COVID-19 virus. 5. Supplements and drugs. Use of vitamin and mineral supplements are critical for a well-functioning immune system, but not for the treatment of COVID-19. Hydroxychloroquine or antibiotics does not reduce deaths among hospitalized COVID-19 patients, nor help people with moderate disease. 6. Garlic and spices. There is no evidence that eating garlic prevents COVID-19. Also, adding pepper, turmeric to your soup or other meals does not prevent or cure COVID-19. 7. Saline nasal wash. Rinsing your nose with saline does not prevent COVID-19. Finally, do not fall for these myths about preventing or treating coronavirus. This concludes the management and prophylaxis of COVID-19. Bibliography.
We sincerely thank Rajna ma'am for all her guidance and during the whole presentation. Thank you. Thank you.
Thank you.
Okay.